Welcome to the 7 Domains of Women's Health. I'm Dr. Kirtley Jones from Obstetrics and Gynecology at the University of Utah, and we are going to talk about turning 50 or midlife. What is midlife? Is it the middle of an 85-year-old lifespan? That would make it about 43. Well, if you don't count the first 15 years of your life because you were a kid and not a completely sentient being, sorry, kids, you may be more sentient than many of us adults, so 85 minus 15 is 70. Divide that in half and it makes 35. Add the 15 back and you get 50. I know that's a little bit of a arithmetical game, but that's what I was aiming for, because the number that most women also relate to menopause is 50. Most psychologists consider midlife as being about 45 to 65. And for most women, it's also the time of their menopausal transition. We're talking about midlife in this 7 Domains session. Specifically, we'll be talking about midlife and menopause. They're different, but they happen about the same time, and there's a lot of overlap. We're going to give this a big think. And with me is going to be my co-host for all these 7 domains, Katie Ward. Katie's a women's health nurse practitioner and North American Menopause Society certified menopause practitioner. She's faculty at the University School of Nursing, and she's a PhD candidate in anthropology, so she knows all about people and women. She's been with us in the 7 domains before, and she helped us with the 7 domains of personal grooming. You should definitely check that one out. She's going to be Katie. This is going to be the Katie and Kirtley show, so welcome, Katie.
Thank you, Kirtley. I'm so happy to be here. And I love talking about menopause and midlife.
Oh, good. Well, midlife and menopause are very different experiences, woman to woman and culture to culture. The biology is similar, meaning biologically, French women and American women and African women and Asian women are similar, but the outcome and expectations are different. So, Katie, let's share with us your menopause or your menopause transition.
Well, it's very personal. I sort of plan to avoid the transition. So in my 40s, I went on birth control pills, and I was pretty happily going along on birth control pills when my daughter got a blood clot from her birth control pills. And so out of solidarity, I switched to an IUD plus estrogen. And aside from some heart palpitations, which I think we're going to talk about a little bit, I have not had a hot flash.
Oh, yay you. So it turns out that a lot of female physicians, women physicians who know deeply about menopause, preemptively decide to manage their menopause smoothly so that they kind of smooth the transition from regular cycles to perimenopause to menopause. And they don't really know when their menopause happened because they just kind of glided their way through. That sounds like you, Katie.
That's exactly what I did. I couldn't tell you when exactly my menopause was. Maybe it hasn't happened yet.
Oh, I think it has. Well, so I was happily managing my menopausal transition. And I was on a birth control ring. And I thought at about 54, I would stop my ring and go on a low-dose hormone replacement. And I would just make the transition that way. However, after a long airplane flight from Florida, I had some really bad right upper quadrant pain. And I didn't put 2 and 2 together. I thought the problem was my liver, but of course I go to the ER and they tell me I have clots in my lungs. I said, oh, okay, well, that was it. So I went right to the potty and I took out my ring, and that was my menopause. I had a little tiny period. And for me, hormone replacement was not really an option because I'd had a clot. I did not have one hot flush, not one. And I came from a family of serious hot flushers. My mom and my sister are powerhouses in the flushing business. I never had one, but I had very significant muscle and joint pain. And I knew this was coming because of my experience that just before my period, when my hormones would drop, I would have muscle and joint pain. So I had this long-term plan of managing my muscle and joints through my menopausal transition by taking hormones, but that didn't work. So here we are. We are not the hot flush queens, you and me, Katie. We managed to be those 15% of women who don't really have hot flushes. And I think we're lucky.
We also have the experience of talking to lots of people who
Oh,
suffer
yes.
terribly from them.
Oh, yes. Oh, yes. And having watched my mother and talked at great deal with my sister and some friends. Well, Kitty and I have long time menopause practices, and there are a list of symptoms that women have brought to us when they are about 50, say 45 to 65. And some of them are truly related to the loss of ovarian function and falling ovarian hormone levels. And that comes with menopause. But some of these symptoms are aging, and they happen in midlife when we're aging accelerates a little. And some are a crossover and a little bit of each. So Katie and I are going to play a little Jeopardy game and see what we think causes a bunch of symptoms and how we might approach them. But before, how do we know? How do in the research is because we all read the literature. How do we know if it's menopause or aging? Katie, how do you know if something is menopause or aging? How are you informed by science?
Well, so menopause, and I always try to explain this to my patients, is women are born with all the eggs they're going to have. And it's actually the follicle making the egg that makes the hormones. So when you're out of eggs, when you've depleted that ovarian reserve, you don't have the factory to make the hormones. There's a bit of a transition as you're down to those last eggs where things can be unpredictable, and then there's a point when there just isn't a factory to make estrogen and progesterone anymore. I think understanding that these are hormones made by the process of ovulating when ovulation ceases, that there's not a source for those hormones is really an important little tidbit of information that is helpful, because I think what I hear a lot from my patients is that they think that their ovary is a gland that just sort of steadily makes a hormone, and that understanding of that this is coincides with also ovulating helps to understand why it fluctuates so much from month to month, and why it's declining in your 40s, and then what's happening when it goes away, it coincides with the end of your periods. And so by definition, when your periods stop and you haven't had one for another 12 months, that then we know you're in the postmenopause, you've had your final menstrual period and you're now postmenopausal. But there's a period of time right around that final menstrual period when things can be a little confusing. You might skip a few periods and then have one that you weren't expecting. They might get closer together. In fact, frequently they do get closer together in the lead up to the final period. Each month, things are a little bit different. Hormones are fluctuating, symptoms are fluctuating, and you think you've got this figured out, and then it's different.
What ticks me off are those menopause tests or a dipstick that says you can check your pee and you'll know if you're in menopause, because I hate that because sometimes you're up and sometimes you're down. And what do you think?
It's been so frustrating. I feel like women want to understand when their periods are going to be over. They're trying to understand their health. They're looking for
A blood test.
well, I mean, I there's just this whole industry that preys on women right now, any way to make a buck. And what better idea than to sell women a test that's going to be different every single month? So whether it's a hormone test or a dipstick or a clinic that says you have to come in every 3 months and supply a saliva sample to get your custom compounded, product. And these are all just people who are preying on women's anxieties and looking to make money off of something that changes every single month. So I'm with you. It's driving me crazy as a provider.
Well, it gets me. I think it's really hard as a clinician because I think women rightfully come in with symptom A, and they're in a transition where tomorrow it could be different. And I don't want them to feel like they're all alone and say, well, you're just going to have to wait it out a little bit, or I don't know when your next period's going to come. I don't know when they're going to stop. It's hard, I think, to be a clinician who listens and wants to be helpful with the body. This is why you and I both chose not to let our bodies talk. We shut off. We shut off our ovaries for the menopausal transition.
Well, and I think we both have brought up something that that also gets underestimated in some of these direct to consumer treatments is that there's some risks with going on hormone therapy.
Oh, yeah.
And that happened to you.
Yeah.
And it also happened to my daughter. It was birth control pills, which are different than hormone therapy, but birth control pills are one of our treatments, especially in the perimenopause period of time. And so I think that that is an important thing. I don't want to overstate it, but it is an important thing that women making decisions about menopausal hormone therapy need to weigh is that there is a risk of blood clots and there is a small risk of stimulating some breast cancer. And so the discussion I want to have with my patients is, the risks and benefits for them.
When you say small, your idea is small and your patient's idea of small might be a little different. But I think the number I use is 1 extra breast cancer per 1,000 women per year and 1 extra blood clot per 1,000 women per year. Those are the numbers. I don't know what numbers you like to use, but those are the ones I use.
No, that's about exactly what I use. I guess I look at 1,000 women using it for 5 years and say 5 extra breast cancer cases, but that's that's the same math.
That's higher math for me.
I like
I'm
your
sticking
math.
with it. Right. We're going to play kind of menopause Jeopardy, sort of like that. I'm going to call out a symptom, and then Katie and I will say whether we think it's menopause, midlife aging, or just we'll call it midlife, or both. Katie, are you ready?
I think so. Maybe we should take turns because I don't want to get these all wrong.
Okay, then I'll do the first one. You can do the second one, okay? All right, ready? And we're going to do hot flushes first. Think about it.
Hot flashes, menopause.
Okay, menopause. I agree. So we both agree that hot flushes are menopause. There are some other things that can cause hot flushes, but they're kind of rare.
Your thyroid, maybe.
Yeah. And then there are people who have alcohol-induced flushing. There's some really rare tumors. But I think that if you've got hot flushes, they last about 3 minutes. It's not being hot all day, but they last about 3 minutes. And sometimes you kind of know that they're coming. You have little symptoms like maybe your heart's beating a little faster or you have a little tingling. But that's a hot flush. And that's for sure menopause.
For sure. Now, the best friend of hot flashes, night sweats.
Menopause.
Yes. And I think this is one of the things that women complain about a lot is maybe they're not getting hot flashes during the day, but in the middle of the night, maybe they don't even feel the hot flash portion of it. But after this hot flash where your temperature spikes top to bottom, then your body does exactly what your body knows how to do to cool you off, which is to break out in goosebumps and pour sweat over the whole of your skin. And so women wake up because now they're suddenly drenched in sweat and their sheets are wet and they're throwing the blankets off and they can't cool off fast enough. And then they're wide awake in a wet bed and need to change their sheets. And so the night sweats can be really disturbing because then you've got to fall back to sleep in the middle of the night. So that triggers a whole other cascade of problems, disturbs your sleep partner and increases your anxiety. And
So we all drop a degree of temperature at about 2 in the morning, or depending on our biorhythms, but we'll just pick the average 10 o'clock bedtime person. And at about 2, we drop a degree of temperature. So all of us can get a little sweaty in the middle of the night. We know this because of our babies, right? We go check in our babies that we covered with all these blankets, and we check them in at 2 o'clock, and sure enough, they're just sweaty and they've kicked everything off. So we do this, but the hot flush business is one that can happen multiple times through the night, and it's miserable. I wouldn't want that. So what's your favorite treatment for hot flushes and night sweats, Katie?
estrogen,
Yeah, mine too. Are you ready for breast soreness?
menopause.
Well, during the transition, when there are some cycles when your estrogen is really high, and when your estrogen gets really high, it can make your breasts sore. Or when women who've been away from hormones for a while and just start estrogens, they might have breast soreness. So I think of breast soreness as being part of the rockin' and rollin' of the menopausal transition. What are your thoughts? I don't know.
I agree. And certainly for somebody who's, as we were talking about, some months you still make an egg and some months you don't. And that may be a place where you start on some hormone treatment that you weren't using before and you get some some breast tissue response to that. So sometimes it's changes in your cycle and sometimes it's the treatment. But certainly, the aging component, the midlife part, as you get beyond that final menstrual period, then I don't expect to see so much breast soreness. And I think about it differently.
Yeah, yeah, I agree. I agree.
I get this question a lot. Decreased libido.
Huh. That's my answer. Huh. How about both?
Both.
Well, it's hard to say because it can be relationship, it could be midlife, it could be hormones. I don't know. What do you think?
I like to dedicate a whole visit to this. So when I see patients and they tell me that they're looking for hormones to treat their libido, um, I want to kind of separate those conversations. And I think the libido is such a complicated thing for women that it really deserves an opportunity to talk about all of those things. What was a time when your libido was great and what was going on in your relationship at that time? There're just so many things to think about. And so I never tell a patient, "Oh, yeah, I've got a hormone treatment that's going to change your libido." Like that really requires a lot of other things. It might be a sign of other aging issues, diabetes, high cholesterol, blood pressure. There are lots of things that can, where libido might be the tip of the iceberg for other, another medical workup. So that's one thing that's on my mind. And then, yes, as you said, the relationship issues and so much complexity. So I certainly don't promise my patients that hormone therapy is going to fix their libido.
Yeah, especially if you've been in a long relationship, it's sometimes that relationship morphs into a more enduring friendship, but it's not the sex thing anymore. It's not a whole erotic thing. So I think it's pretty difficult. I mean, you can have someone who said, I had a great sex life until my ovaries came out, and now I don't. And I know it happened on this day. And that might give me they had their ovaries removed as part of a hysterectomy. But I think it's a tough one. And you're right, it takes a long conversation.
It really does, and exploring a lot of different issues because again, there are a lot of possibilities on the table, and there are also a lot of good treatments. So there are just so many, so much complexity to the female libido.
Well, the next one, vaginal dryness, and what do you think about vaginal dryness? Would you definitely say that is
Definitely menopause.
absolutely? And all you need is a couple, sexual encounters with your partner that is painful, and it could make your libido just run away.
Yes, a whole cascade of if sex hurts and you're anticipating something painful, it's very hard to get aroused. And then if you attempt intercourse and it confirms your suspicions that it's going to be painful, then that just reinforces that cycle. So I think that is a place where we really can provide women some help with some local estrogen. The vaginal and vulvar tissue really misses estrogen when it's gone, and the local estrogen does not have the same risks as systemic estrogen. So most everybody can use that.
And there's some other things out there too. It's a bunch of other products and a bunch of other hormones that might be helpful, but local estrogens certainly they're easy to take, and a bunch of different ways you can take them. You can take it with a little pill in the vagina, or there's some cream or a ring, and you get to choose. And I think it makes a dramatic difference about that. And so let's jump down, Katie. Recurring UTIs?
Partly are recurrent UTIs, menopause, midlife, or both.
I'd say it's menopause, although it could be aging. It could be aging because we know that ladies, as they get older, do have more urinary tract infections. But the biggest thing that we can see is that the natural defense mechanisms against urinary tract infections um, kind of go away, get thinner. The tissues get thinner. They don't fight bacteria as well. And so I think this is really amenable to local estrogens, and it can, in randomized trials, it shows it definitely makes a difference for most people. I don't know what you think about, but
No, absolutely. Yeah. So even we were talking before about vaginal dryness interfering with your sex life, but even if that is not the thing that's bothering you, UTIs become a real health issue for people as they age. And so even for women who are way beyond being concerned about a sex life, UTIs can be a health issue that leads to some mental status changes for very
Oh,
elderly
yeah.
women
Yeah.
and
Mhm.
makes people quite sick. So I think a little bit of local estrogen, if it helps prevent UTIs, can
Oh,
help
yeah.
people even in the frail, way beyond midlife and into, frail elderly years. So a little vaginal estrogen, I think, can go a long way
Oh,
towards
and
helping
UTIs are miserable. They're just miserable. So, how about headaches? You ready for headaches?
all of life.
All of life. So, right, life makes headaches. Some people, I think, when they take hormones, if they haven't had hormones for a while, they might get headaches. And it depends on the kind of headache. Migraines actually get better at menopause, and they might come back if you add estrogen. But some of them's coming with new headaches at 50.
Well, so new sudden onset headache at 50, I'm not going to say this is just menopause. I think I'm going to work that up a little bit more
Yeah.
for other health concerns. So I think new symptoms at 50, like I'm still going to be looking for all other kinds of health issues. So I like to do a very thorough history and physical and lab work and be looking at concerns for, again, high blood pressure, high blood sugar, high cholesterol, other issues that we can treat that are part of aging. But I also want to get a headache diary and if there are any concerning neurologic features. So I'm not going to attribute that necessarily just to her menopause. It might be part of the picture, but
Yeah, I think we have so many good treatments now for migraine.
we really
If someone
do.
comes and says, I have the worst headache of my life, it's just the worst terrible pain, then they get a visit to the emergency room.
Yes.
They don't get to pass go. They said, come on, I'll walk you over.
All right. Let me ask you a hard one. What
Okay, go
about
for it.
tinnitus?
Oh, well, that's a tough one. That is really a tough one because it supposedly is a little bit more common in the menopausal transition, but giving estrogen replacement doesn't make it better. So I'm not sure what it is. I'd say it certainly increases with age. So it's more common in midlife than it was at 30. It's more common at 60 than it is at 50, just because we have more accumulated damage to our inner ear from loud sounds. What do you think about that?
So much of this is a little bit of prevention. Oh, midlife is that time when your lifestyle and your habits catch up with you, right? And the habit of caffeine or
Oh, yeah.
alcohol or
Oh, yeah.
rock and roll starts to take a toll on your body. So I think a bit of preparing for midlife, and this is maybe something we hit on before in terms of women who work in this field kind of planning ahead, but it's really shaping the trajectory of our aging early on to make sure you're establishing healthy habits for exercise and diet and things you do for stress relief and keeping in mind the wear and tear that places on your body as you age.
Are you ready for sleep disturbances?
Ooh,
We'll just group it sleep disturbances.
menopause.
Oh, I'd say both. Well, it kind of depends if it's got hot flushes associated with it. So I think there are a lot of things happening in midlife women's lives. They're aging parents, they're disruptive teens, they're cranky husband that lead to insomnia and difficulty getting back to sleep when they wake up. So I'd say if it's hot flush, it's definitely menopause. If it's situation, it's probably midlife just because things pile on. And then there's restless legs, which are increased in women. It's more common in women than it is in men. And it's underdiagnosed. It increases with aging, but it doesn't get better with hormone replacement. That sense of got to move your legs feel kind of itchy or movie, and you got to move them around, and you can't sleep, and that can be with aging. But hormones don't make it better.
True, true. But there is a lot of sleep disturbance that does
Oh
get
yeah,
better with menopausal hormone therapy. So
absolutely,
if
absolutely.
estrogen helps with the hot flashes and the night sweats, and then the other half of the menopausal hormone therapy, progesterone, prometrium, actually does help women sleep. And so
I'm a fan.
for women that are having a lot of sleep disturbances, and who are in that age range around 50, thinking about menopausal hormone therapy might be a good way to help their sleep, both reducing the hot flashes if they're having them, and progesterone because it's helpful in promoting sleep.
Yeah, I think natural progesterone is a really good option because it makes normal sleep. It's not like a sleeping pill, which sometimes can make weird sleep, not normally normal sleep patterns, but progesterone can just make you a little sleepy. So I'm a fan of that for people.
Absolutely. And people can take progesterone alone. So
Yeah.
not everybody has to be on an estrogen as well. And I do have some patients that just take the prometrium, the micronized progesterone, um, without the estrogen. And I've had people have great effects on their sleep. So, Curtly, I want to ask you about your one menopause symptom. You talked about not having hot flashes, but you did have joint pain. So, is
Right.
joint
Right.
pain menopause, midlife,
Yeah.
or both?
Both. I'm sure it's both. But falling hormones can be associated with stiffness, and it's probably ligament stiffness. It's not actually arthritis. It's not a damage in the joint itself. But many people, and it came out of my own experience was I would know when my period was going to come because I'd wake up in the morning and my feet and my shoulders would hurt. And I'd say, okay, these are going to be my menopausal joints because when my hormones fall, these joints ache. And it turns out in the Women's Health Initiative, um, one thing that did fall out, that was that huge trial where they randomized people to placebo or hormones and looked at a whole lot of symptoms. And one that actually did get better on hormones compared to placebo was what they called arthritis symptoms or joint symptoms. Or
Mm-hmm.
so women don't always say, they say, "Oh, I feel old. I'm feeling old." And if you pull that out, they say, "What do you mean by you're feeling old?" I say, "Well, my joints hurt, and they didn't used to." Well, certainly that can be aging, but it's one of those things that does get a little bit better with hormone replacement therapy. So would I give people hormone replacement therapy if that were their only symptom? When exercise and stretching would probably also make it better. But it's a good thing to remember that out of the randomized trial, joint discomfort turned out to be a little bit better with hormone than placebo. Yeah, it's not the joint capsule like we think of people needing hip replacements or stuff, but the ligaments shorten, they get tighter around the joints when you stop estrogen. Estrogen makes us more flexible. We can touch the floor better than our husbands can. And when our estrogens are gone, those ligaments get tighter, which means it hurts a little bit more to move around.
And I think we have more to learn on this subject. So,
Oh, definitely.
women's hormones, the hormone that we make in pregnancy, and I think we make it in each menstrual cycle, relaxin, that is important for facilitating childbirth, changes our joints just a little bit. So it makes sense to me that there's a connection between our hormones and what's happening in our joints that probably deserves a bit more research than it's had. But I think that there's definitely a connection between wear and tear on the female joint and what's happening with our hormones. So the anthropologist in me says this is an interesting avenue for a little bit more research about things that are unique to women.
Oh, I think there should be a lot more research because it's so common.
Yeah, and so there's usually a couple of things happening. Most people do have a little osteoarthritis,
Yeah.
and you can see that in joints that have had extra wear and tear. So it may be more on your dominant side or your knees if you've been a runner, or there are places where you might predict a little bit of osteoarthritis. But I do definitely see that as a complaint that gets better when I'm giving people hormone therapy. So there's definitely a midlife component, but there's also a wear and tear component. And then for somebody that's got joint pain everywhere, then I'm also looking for autoimmune conditions.
Yeah. Well, Katie, I'm going to give you the one that most women come and complain of, and that's weight gain.
I wish I could. It's so interesting because on one door of my clinic, I have a whole line of women afraid to go on hormonal contraception because they're afraid of birth control, and then another line of women in the menopause who are asking for hormones to help with the weight gain that they're having from lack of hormones. So I think women get very confusing messages about how hormones affect weight gain. But we do have some data that women who use menopausal hormone therapy in the midlife menopause transition seem to gain a little bit less weight than women who are not using it. And that could be a bit of a healthy user effect because those are the same women going to their healthcare provider and getting health advice and getting their cholesterol tested and all the other things that we've talked about.
Getting their joints to feel better so they're willing to go out and move a little bit more.
Yeah. But I can't tell anybody that going on hormone therapy is going to produce weight loss.
They can't blame it on their ovaries either. They can't say
no. So that requires going on a diet and being uncomfortable and having, getting into a calorie deficit somehow. And it is just really, really hard.
Boy, that's a hard thing to tell people though, isn't it?
It is. And nobody wants to hear it. And everybody wants a magic pill. And although we do have some medications that can help people lose weight, they, like anything else, the effect of that stops when you stop the medication, and everything is going to come with some other risks. So like other things, it's a very complicated conversation with lots and lots of contributing factors.
Yeah.
Your genes, your habits, your diet, the sad American diet, so many things.
I'm sorry about that one.
Currently, this has just been amazing. And as we've touched, I think we've just only touched the tip of the iceberg about all things midlife and menopause. And there's so many other complaints and concerns that women have and joys that we haven't talked about yet. So I am really looking forward to doing a bunch more episodes where we can take a deep dive into a lot of the domains of women's health. So we're going to talk about the social domain and the intellectual domain, and we're going to talk about anxiety and depression and how much of that is related to menopause and midlife, and being together and being single, and financial planning and spirituality and grandchildren and some of the joys of the middle part of your life and planning for healthy aging. So I am really looking forward to taking a deep dive into more of these topics and exploring some of the things that we haven't had time to touch on today. So if your menopausal concern didn't get into today's podcast, I hope you'll come back for the rest of the 7 domains of women's health.